Good afternoon, everyone. This is Ann Kuppinger from the Community Technical Assistance Center, or CTAC. I would like to welcome everyone to today's webinar. And we have a number of people still signing on, so we're going to let them do that for just a couple minutes, and we'll be right back with you. You'll see a note in the chat box that lets you know how to call in if you prefer to be listening to this audio through your telephone rather than your computer. If you are listening on your computer, you can turn up your volume so you'll be able to hear the conversation. And we'll be back in just a minute with an introduction and some more WebEx navigation instructions. Thanks. Hello again, and welcome to everyone. Thank you so much for taking the time to join us. I don't know what it's like where you are in New York State, but here in Albany, it's a beautiful fall day, and I hope you're enjoying that. My name is Ann Kuppinger. I'm with the Community Technical Assistance Center, or CTAC, and I am really excited that we're going to be having this opportunity today to talk about family peer support services and partnerships with hospitals. This is a really exciting topic, and we hope to be doing an occasional series of this kind of webinar over the course of the next year or so, where we introduce everyone to different kinds of partnerships that are going on between family peer support providers and other programs across New York State. Here in New York and elsewhere across the country, we're seeing an increase in partnerships with family peer support programs and a variety of crisis, emergency, and hospital programs. You know, we see folks working together on mobile crisis teams, in emergency rooms, in acute inpatient settings, long-term hospital settings, state-operated hospital settings, and in crisis stabilization type programs. And while the evidence is still emerging, we really are seeing a lot of preliminary signs that this is turning out to be really beneficial for families, and also beneficial for providers as the family support programs are able to help people make better connections in the community, and really having an impact on some of those measures that are going to be so important going forward, reducing emergency room visits and recidivism to hospital and things like that. So, you know, we are aware of the fact that there are a lot of folks across the state that are doing really interesting work in their hospitals with family advocates. And I want to start the webinar by inviting you to let us know what you're doing, because we'd love to have the opportunity to share your good work with other people as well. You'll get my contact information and the contact information for the presenters at the end of the webinar. So before I turn it over to our presenters, I just want to orient everyone to how this WebEx system works. We have a lot of people on the phone today, so we won't open up the phone line, but there is a chat box. So if you look at the upper right-hand corner of your screen, you'll see a blue speech bubble and it says chat. If you click on that, it will open a chat box. And you can communicate with individual people or with the entire group by selecting from the drop-down menu who you would like to chat with. If you have questions, we're going to try to leave some time for questions at the end of the webinar, and our presenters have also offered to answer some of those questions offline as well. So chat your questions in as we go along, and we'll take as many of them as we can when we're finished. So just in case, many of you have probably heard of CTAC and MCTAC, but just to give everybody a sense of what our group looks like, we're a collective of really experienced, talented organizations from across the state who are working together with providers who are equally experienced and talented to try to help everybody make this transition to managed care, and in the context of doing that, really step up our game in terms of our clinical best practices and the best practices of all the services that we provide. So you can see a list here of all the CTAC partners, and of course we consider each of you providers a CTAC partner as well. Again, at the end of the website, we'll give you at the end of the webinar, we'll give you the websites for CTAC and MCTAC, and we hope you'll check out some of the things that are coming up in terms of training and technical assistance, and there are a lot of recorded events there as well. So without further ado, I'm going to turn it over to Jenny Laney, who is with the Mental Health Association of Erie County, where she is the director of the Child and Family Support Program, and she is going to introduce the team for today.
Welcome, everybody. It's my pleasure to introduce our partners and our presenters today. We have Chuck Colston, Program Officer from the Peter and Elizabeth C. Tower Foundation with us. We have Dr. Michael Cummings, Executive Director of Behavioral Health at the Erie County Medical Center, Daryl Taberski, Clinical Supervisor at Bryland Hospital, and Caitlin Newman, Youth Peer Mentor at the Mental Health Association. I'm going to take a minute just to talk about the funding streams here, just to clarify and help answer some questions that might come up later. The Tower Foundation is funding both intensive follow-up at the Erie County Medical Center and at Bryland on behalf of families who have children and transition-age youth. They've also funded a family support partner at the Buffalo Psychiatric Center, concentrating on transition-age youth. The Erie County Medical Center is fee-for-service, so they're paying us to be in the hospital 7 days a week, in addition to supporting both families of children and adults and their caretakers. With Bryland is paying us for a youth peer mentor and family support. The Tower Foundation has also funded a youth peer position, so we have a youth peer through that 3-year grant. The agenda today, I'm going to talk about our Child and Family Support Program. I'm going to talk a little bit about what we're tracking and evaluation, and then you're going to hear from our partners on their perspective of why family support is important to them. So our program, Child and Family Support Program, is a family support program providing support, education, and advocacy for families who have a child with a mental health diagnosis, emotional and behavioral challenges. But what we're going to spend time talking about today is our work with the hospitals. So we have both community programs, but we're also based in the hospital. Our family support partners who work in the hospitals have had a child hospitalized and know what that's like. They've walked the shoes and they've been there. Our family support partners complete the Parent Empowerment Program, which is a training that's necessary for a family peer advocate credential, which we anticipate will be billable through Medicaid. So what do our family support partners do in the hospital? They listen, they share information, and then they offer the opportunity for a follow-up call. When we meet a family, we listen. Sometimes it's a crisis situation. We share information, but we also offer them a consent for follow-up. That's our opportunity to support them while the individual is in the hospital and afterwards. At Bryland, the consent is included at admission, so our focus at Bryland is the children and adolescents. When a family comes through the admission process, our consent is in that admission packet. So the family signs the consent and we immediately follow up with that family. At ECMC, Erie County Medical Center, we are present to ask the individuals, families, to sign the consent. So it's a little different. When we meet a family, we share different information with them. It could be support group information. It's county specific. So although we're based here in Erie County, Families Together in New York State provides us with a family support directory for all the counties across the state. So we're able to link families who are here from, who may be hospitalized from another county with their family support program in their own county. And then you're going to see a copy of the consents that we use. That's just to show you that each is different. At Bryland, we have a little history of who we are because the person is getting this at admission. They're not meeting us. At ECMC, we're standing there giving the person the consent and telling them how we will follow up with them if they sign the consent. And now I'm going to have Caitlin Newman talk a little bit about what she's doing as peer mentor at both the Erie County Medical Center, at Bryland Hospital, and in the community.
Hi, everyone. So 2 times a week for youth peer support, it's the same basis as family peer support, having access to somebody who's been there. So I'm on the unit at Bryland Hospitals and at Erie County Medical Center 2 times a week, and I hear from young people a whole bunch of different things of why it's valuable to them. Number one, the first thing is that they have a voice. They feel understood. You know, when I go onto the unit, it's different than the typical way of providing services. You know, talking to clinicians and talking to people with degrees. You know, I'm just a 20-year-old girl who has experience within the mental health system, and that's different for them, and that's really special. So I understand what they mean when they say that they simply can't get up in the morning, and sometimes just battling the day is their greatest accomplishment, and that's something that I do relate to. And yeah, and having access to somebody who can connect with someone on a personal level like that gives them a voice, and that's valuable. So qualifying factors, for us, I know it's different at different facilities across New York State, but for the Mental Health Association, I had to be out of the hospital for at least 2 years, and the obvious experience in children's system of care. And I also am trained in Waiver Youth Peer Advocate through Cornell Cooperative Extension and Youth Power through OMH, and a trained youth peer, youth mental health first aid instructor as well. And some of the other things I do at Bryland is sit on their committees. So one of the committees listed is the Incident Review Committee, as well as PARS Committee, which is Positive Alternatives to Restraint and Seclusion, and providing consumer representation and a youth perspective on these committees. Because realistically, you know, when people are talking about service recipients, we should be sitting at the table and we should be having a voice. So it's a wonderful collaboration. And activities that I do on the units, I'm going to talk about that in the next slide. And another hat that I wear, as well as my position at the Mental Health Association, is president of Youth Power's Board of Directors, which is the New York State network of young people who have been labeled and are seeking change. And it's an incredible resource in New York State, and it gives me access to peer support resources and as well as assistance to help guide our work and our mission for the next couple of years within our grant. So for the paperwork that I fill out each month, Jenny and I fill out and send calendars to each of the hospitals, planning my groups in advance. And realistically, I know that I have to have a backup plan each time, because sometimes I go on the unit and the young people don't want to do something because they had a really rough day. But it's my job to give them what they need. And if they say, Caitlin, we just want to hang out and talk about how, you know, talk about anything, you know, and sometimes those are my best groups when I have a backup plan. And anything that they want to talk about. If they want to talk about, you know, how to stay self-harm free, if they are interested in talking about, you know, things that they're worried about. One of the activities that I do is an open discussion / structured venting group, and we talk about things that are relevant to the young people and things that they're constantly worried about. And it's really amazing to see the young people say, you know, I completely understand what you're going through, and I understand, and this is how I overcame it. And it's not just me who's facilitating the discussion, because I'm at the same level as them. We're all peers together. So we hear questions such as, like, how to manage social anxiety. I'm getting discharged and going back home soon, and I'm worried about what my friends and peers are going to ask me and where I've been. How do I tell my doctors that my meds make me tired, and how do I get them to understand my perspective? How do you keep fighting? You know, what gives you hope? Stuff like that. And so we have these groups, and then one-on-one if the young people request it, if they don't feel comfortable talking in group, and then I fill out everything that we discussed in group, and then I give it to Jenny afterwards. So yeah.
So that community link, thanks to the Tower Foundation, we have a teen support group twice a month here at the Mental Health Association, and we see a lot of young people coming out of the hospital attending the support groups, both from the Erie County Medical Center and Bryland Hospital. So I'm going to talk about our hospital partners. Each one is a little different. The Erie County Medical Center is a 162-bed inpatient unit. We're present there 7 days a week, and as well in the psychiatric emergency room. So most of our time is in the psychiatric emergency room, but we do each day visit the behavioral health units to meet families that we may have not missed in the Comprehensive Psychiatric Emergency Program, which is also known as CPEP, at Bryland. Bryland is an 88-bed acute care psychiatric hospital, and it has 20 beds for children and adolescents. So we see children of a younger age at Bryland, but we're supporting these families on the visiting unit as well as going to the adult unit because we want to meet families who have transition-age youth as well as the transition-age youth themselves. And Caitlin has been visiting the adult unit to check in with youth that are between the ages of 18 and 26. Although we don't ignore anyone, we're there really to provide support to everybody. Buffalo Psychiatric Center is new. It's a state facility. We are concentrating on transition-age youth and their families. We did have a family attend one of our support groups right out of, the young man was discharged from the Buffalo Psychiatric Center, and he met our family support partner at the Buffalo Psychiatric Center and came to our young adult support group. So we're really there trying to support families and link them back to the community. So this, why did our hospital partners ask us to increase hours, and why is Tower Foundation funding us? This is about building a partnership. I attended a support group at the Erie County Medical Center about 13 years ago. We have been doing support groups at both hospitals for almost 10 years now, a little over 10 years. So we've come to know our partners, administration. Of course, there's staff turnover, but it's really about the relationship and the trust in what we're doing in supporting families. Okay, where's my next? So you can see here a chart of growth. In 2011, we started doing a support group twice a week. So we were doing support groups about twice a month. We started doing a support group twice a week in 2011, and then it grew, and now in 2015, we're in the hospital every day of the week, including the psychiatric emergency room. So now I'm going to have Dr. Michael Cummings from the Erie County Medical Center talk about why the hospital values family support.
Good afternoon. First, I really want to thank the opportunity to kind of be here and give our perspective. This is kind of a long time coming for us, and this partnership with the Mental Health Association and also with Jenny Laney in particular. I was just kind of reminiscing. I started my career as the director of the Adolescent Psychiatric Unit at Erie County Medical Center and first met Jenny as a mom on that unit. And to have had that evolve over the, I don't even want to say how long ago that was, over the last 12 or 15 years to where we have this incredibly valuable program within our hospital system. I won't go on for too much simply because I think probably the question period will be the most fruitful of this. But for people who aren't aware, Erie County Medical Center has typically the busiest psychiatric emergency room by volume in the state. Sometimes we lose out to Bellevue. And we have a huge catchment area, everything from rural to inner city and everything in between, with a very diverse population as well. We have also in Buffalo a very large international population. And so we treat a lot of folks. And to me, one of the main initial values of the family support within our psychiatric emergency room is, as clinicians know, it's a very busy process. And sometimes what gets lost in that is that while all the individuals and families are there for help and treatment, they come in many different ways and have many different experiences. And often it's difficult for the frontline clinician to really separate this is an individual with their child, with their first time in a psychiatric emergency room, maybe their first time with psychiatry at all. This is someone who has come in with a first responder, police, or crisis services, and maybe not voluntarily for the first time. Folks who are coming to our psychiatric emergency room very frequently, in some ways almost as a lifestyle rather than as a treatment orientation. And having someone who can help talk and guide those families and not just the families, but our clinicians as well about their perspectives and help them through that process, especially when it's an initial process, is huge to us. There's nothing worse than a family that has to reach out for psychiatric emergency care, having a really bad first experience based on how the system is, and being hesitant to reach out subsequently. So that's, I think, one of the first initial things that we really see. The other thing that's extremely helpful, and we have, as you'll see, so much time and so much touches with the Mental Health Association and our families and patients, is they can help guide and be navigators across the process. But I think what's really valuable is the follow-up that they can provide afterwards, because when you're in a time of crisis, you often miss some of the salient details that were explained, maybe confused about what the follow-up process may be. And Jenny and her team being able to help them navigate long-term is really a vital piece, both for their improving and their stability and recovery, but also just making sure simple barriers to linkage and other things can be addressed. So it's helpful for them pushing that information out to families, but more and more, it's also helpful for us to hear both about our successes and our failures after the fact from the families. And, you know, sometimes it's hard and it's easy to be defensive about those things, and we'd like to hear directly from families and their perspective as much as possible. But having Jenny's team do that really, you know, it helps us kind of put that into perspective and then start working on making systemic changes to meet whatever those individual concerns are. And then just briefly, I'm heavily invested locally within the Medicaid reform district process within Western New York. And really, as I get more and more into our individual projects, and each one of those projects, regardless of what its definition, is heavily involved with behavioral health. To me, the glue that's going to drive this sustainably and make it work over the next 5 years of Medicaid reform just lies so heavily on both peer and family involvement. It becomes self-fulfilling prophecy that when you use peers and families and community-based treatments, it's culturally competent by definition, it's meaningful to the family, and it's sustainable. And so those are really the perspectives that we have with what has been just a wonderful interaction with Jenny and her team.
So now we're going to hear from Daryl Taberski, who is the clinical supervisor at Bryland Hospital.
Hello, I'd like to thank Jenny and the Mental Health Association for not only having a presence in our hospital, but also having me part of this webinar today. I'd like to talk about a few things. I guess also just mention that family support and peer advocacy, it's important to have both components. I think that, you know, you meet with the families, but you also meet at the level of the individual patient, the youth. I can't explain enough how much Caitlin has such a huge impact with our youth and our transitioning adults. So why we partner with the Mental Health Association and why we have family support and advocacy. At the hospital, we do our best, and I think most hospitals do, to try and provide comprehensive care and not just have one-dimensional care in their hospital. I think to do so, it's absolutely necessary to have some component of family support, peer advocacy, to provide a personal touch to empower, support the youth, adults, and families through recovery. And speaking with Caitlin before, as she mentioned, she's been part of some of our committees, and as an admissions packet to describe what it is she does, she explained her approach as delivering a message of hope, strength, and recovery. And those seem almost like cliche words in mental health, but I think when as Dr. Cummings was mentioning, a lot of times we're so focused on our clinical tasks. And I think the staff, the clinical staff, along with the patients, along with their families, can truly learn a lot from our advocates and from family support. To have these guys involved in our process, along with direct care, is huge. Caitlin's even been part of our committees for redesigning our program on our child and adolescent unit and helping us with simple things, even like language on safety plans and things of that nature. So I'd just like to leave it at that, and thank you guys again.
Thank you, Daryl. So our next slide just lists some of our community collaborators. We can't do this alone, so we have foundations listed here, other organizations that we work closely together with. One of the families that we did meet at Bry-Lynn actively engaged in an art program that was funded through the Children's Guild of Buffalo, and now is an active participant in the teen support group and our family support group. So that's one example, but collaboration is critical. Program evaluation. This next slide is going to show you a picture of our hospital database. So we're tracking all contacts, we're tracking all referral information, and we're tracking outcomes. From the database, we can do a report on who needs to be called first. So when our family support partners come in to do the follow-up call, they can look at who has not received a call, and then who maybe is urgent. So our Jack Woodworth, our Director of Operations, has done a phenomenal job in creating this database that went live January 1st of 2015. But it's really critical to be able to go to this, to be able to know what we provided the person and to track what the information shared on the follow-up call. And then you're going to see some charts. We track information on number of consents received. At Bry-Lynn, it's a high rate because, I think about 98% of people sign the consent, it's given an admission. At the Erie County Medical Center, we're meeting people and asking them to sign the consent. So we've tracked this from year to year. We look at and ask ourselves, why are some people signing, why they're not? Again, trying to do a better job, so quality improvement. About a third of the people we meet at the Erie County Medical Center sign consents, and we're not there 24/7. So our goal is to be able to include our information on the discharge paperwork in the Comprehensive Psychiatric Emergency Program, also known as CPEP, so we can be following up with every individual that walks through the doors. So that's been our ongoing conversation with the administration from behavioral health at the Erie County Medical Center. So why have we experienced success? We're meeting families where they are, and sometimes it's difficult to meet a family in crisis, and we're okay with that. If a family, puts their hand up and it's not a good time, we'll give them information and they can call us. Other families are ready to hear that we've been there and we understand what it's like to be sitting in a psychiatric emergency room. So again, meeting families where they are. Even though we do support group, families are busy, they have other children, so it's often hard to attend support group in the hospital, but when we're there talking with them, whether it's in the hospital while they're visiting, afterwards at a support group, or in the psychiatric emergency room, we're not only listening, but we're also sharing information. And if they choose to sign the consent, we're telling them we're going to follow up immediately. And we're able to do so, thankfully, with families of children and transition-age youth because of the Tower Foundation. Staffing we were having a hard time keeping up with the volume of consents, and the Tower Foundation has allowed us to do an intensive follow-up call and not more than once. So when we call a family, if they want to call back the next week, we're able to do that. If they say, we're being referred to SPOA, give me a call in a couple of months and check in, and then maybe 6 months down the road. And that's what we're doing. After the families go through SPOA services, which are wraparound programs and waiver programs, sometimes we're able to follow that family and give them respite. So that's the continuum of care that we're providing. So data collection, this is just why do we want to follow up? We want to be able to show people our outcomes and show how family support and youth peer support is supporting families and keeping them out of the hospital. But our focus is also that day-to-day, sharing information with youth who might have dropped out of school. How do they get back to school? sharing information on how to get a job on behalf of our transition age youth, sharing with families that we have a respite program and we have a social skills group, just improving the quality of life for the whole family. So our targeted outcomes are that families feel better supported, they feel less isolated, and that they are engaging in treatment. A lot of families we meet, this is their first time hearing the word mental health. So we're able to talk to them about that and help them navigate the system. And then successfully link them to community resources. It may be a waiver or wraparound program. It may not be our program immediately, but that's what we're there to do. We send food pantry information, any type of resource. We're also supporting children who may go through the doors and look for eligibility through the Office of Persons with Developmental Disabilities, but we're, again, explaining what that process is, trying to support them at support group as well as provide respite because that family and that child are experiencing crisis. So now I'm going to ask Chuck Colston from the Tower Foundation to talk a little bit about why they chose to fund us for 3 years to do extensive follow-up with the families and children we meet, as well as transition age youth.
Great. All right. Thanks, Jenny, and the Mental Health Association for just the invitation and allowing me to talk a little bit about the foundation's perspective. So basically, the Tower Foundation was interested in the Child and Family Support Program because, one, it aligns with 3 of our goals in our mental health category. We care about children and youth that, in terms of helping them with their social, emotional, behavioral challenges, and also the second part of that is being identified early and connecting them to the appropriate services. And then in terms of our second goal, young people with mental health challenges, helping them understand and manage their behaviors and their conditions. So, and then the third one is really the family component. You know, families being able to understand mental health challenges and help members live productive lives. So those were the 3 goals that they hit right on that really are near and dear to us in terms of the foundation. But also our trustees and staff saw the potential for this project for really helping improve the quality of care and lower the cost, you know, in terms of for hospitals. The follow-up support, as Jenny mentioned, is really a critical part of this project in terms of really helping those families navigate the system. That's something as well we care about. Because as Jenny was saying, these parents are, you know, sometimes they feel like they're on the island, they're isolated and unsure of what to do next. So and anything that we can do to kind of support that was, and the other thing that was really compelling to me was, you know, the rising demand for the service. I think in 2011 there were 300 families that MHA served, but in 2013 that target jumped tenfold. So in terms of 3,000 receiving services, the number I think is continuing to go up. So it was just quite clear to us as a foundation that our dollars could further build the capacity of the staff in terms of being able to, you know, support these families. But how do you, I guess when you look at all this, the evaluation component was also so critical because you're doing, the MHA is doing great work, but how do you just have that proof to show that this project works beyond just anecdotal? So that's what our dollars are also helping to do, to make the case for the program, and also just be able to leverage these funds down the line after Tower funds obviously go away. But this to us is a partnership. It's just not about the dollars. It's something that we want to be able to work and maintain this type of program and effort. And kind of to wrap up here, in terms of this, the big picture for us, I mean, this is a huge impact that goes beyond the foundation's, you know, investment. Project really reinforces the need to support young people in their path to recovery. And then lastly, there's some real dividends in decreasing the number of readmissions into the emergency room. So with that said, so.
Okay, and thank you, Chuck. And Chuck, you know, referred to the number of families. So the more we were in the hospital, I think I was surprised at the number of people who actually signed a consent and said, yes, follow up with me. I mean, that was really validating, saying, yes, I need help. I want someone to follow up with me. So our outcomes from 2014, we saw an increase in families attending our family support groups, our 20-something group, which is a group specifically for young adults ages 18 and up, a group that really we continue to strive to find more funding to support. In 2014 alone, we saw 46 families referred to our Child and Family Support Program through the hospitals. And what that means is we have a group following them on follow-up calls, but our program, the Child and Family Support Program, can go in and do educational advocacy on their behalf, provide them respite. They can attend our program. So that was a good number to us in our first year to serve 46 families that were referred just because of the hospital touch. And families report that they feel better supported and that they are linked to community resources. Some of the accomplishments we've seen thus far this year was the creation of the Teen Support Group. That group averages 12 to 15 young people each. It's bi-monthly, so the young people are coming to that group. The creation of the hospital database, which is really allowing us to track all this information. We're building our youth peer mentor team because Caitlin isn't enough. She's in demand. We're working in the hospital, in the community. Schools are asking her to come in and do groups. So this is going far beyond what we had imagined. And just recently partnering with a residential treatment facility to have youth peer support present there to help those youth transition back home. So I'm going to ask our partners to ask how this meets their hospital goals. How does family support and peer youth support help them meet their hospital goals?
Well, I just briefly, because I kind of touched on this probably in my earlier part, certainly from a patient and family and patient experience perspective, I mean, we want good patient experiences and good outcomes just as clinicians and as healthcare providers, but as everyone knows, that patient experience is also directly tied to reimbursement moving forward and those benchmarks. So from even a financial and fiscal standpoint, it's a vital piece. And then from the larger piece, again, with Medicaid redesign, with the goal of reducing avoidable hospital presentations and hospitalizations, I think these processes and programs like Jenny's are just vital for that. When we look at our high-end utilizers of our psychiatric emergency room, 90% of what brings them in has nothing to do with psychiatric comorbidity. It has a lot more to do with social determinants and what else is going on within their environment. And those things can't be touched with a hospitalization. Those things can't be touched with medication. But they can be in touch with community involvement and integration and people to reach out to. And so that's where I see moving forward this becoming a larger and larger piece of what we do.
I'd like to add to that also, it does help reduce recidivism and provide our patients and their families with more outlets and supports post-discharge, and to have, sometimes that personal touch or that personal experience, talking directly to them about, what they might experience or see at some of these other agencies or resources. But also to alleviate the fear that a lot of families or individuals might have about even receiving help or being hospitalized. I often go on behalf of the hospital to, with our marketers to some of the outpatient clinics and meet with other clinicians and outpatient services, and they often discuss resistance to being hospitalized. And a lot of that has to do with misconceptions or fears of what's going to happen in the hospital. And it's only so meaningful when that information comes from a clinician or someone working at the hospital. But when it comes from someone like family support or a peer advocate, it's a whole nother level, and I think that's really helpful.
Did you want to add anything, Chuck?
I think in terms of from a foundation's perspective, I think this is something that really has the potential to move the needle, not just for MHA, but as you look at as a community in terms of the type of support that is really kind of needed to help these youth and these transition age and individuals to be able to get the support that they need, and the work that the peer mentor is doing, and Caitlin, and the stuff that but it also really just helps free up some time for Jenny and her staff to look at some of the how can we continue the program, enhance the program, and refine it. So I think which is great. So
our next steps are to continue the research to do research, we have to go through the internal review board at ECMC, so we're going through that process presently to show outcomes of the hospital work. We also, one of our goals is, as I mentioned earlier, to have the consent signed by everyone if they choose while they go through the psychiatric emergency room at the Erie County Medical Center. Again, we're not there 24/7, so when families come in during the morning, our shift is an evening shift. We're there usually between the hours of 2 and 8 and 12 and 8 on the weekends. So we are missing some families. So having that consent offered to every family would be helpful to be able to follow up with each family that walks through those doors. And I think just the future opportunity, quality improvement, and another goal is reaching out to Children's Hospital. That's one hospital that we're not present at yet, but that is a future goal. So, Ann, at this point, do you want to see if there's any questions?
Yeah, that sounds great. I want to thank all the presenters, both for the good work you're doing and also for taking the time to share some of that with everybody that's on the phone. We have had a few questions come in, and I would encourage people to chat whatever questions you have right now. We'll also take those. One of the questions that came in was, is this happening anywhere else in the state? And the answer to that is that there are different ways in which family support is partnering with all different kinds of providers, but in terms of emergency services and hospital programs, we're really starting to see that pick up a little bit. In fact, you know, Dr. Cummings mentioned Bellevue. They've been doing some work. Some folks from that are affiliated with the IDEA Center at NYU have been working with Bellevue to put some family support providers in that hospital. I know there are a few other hospitals in New York City where Families on the Move have kind of positioned some of their staff to work in partnership with those hospitals. A number of our state-operated children's psychiatric centers have at least part-time family support providers, and there has been some recent efforts to free up some state items to hire additional family peer support providers to work in those hospitals, and also to, on a contractual basis, place some youth advocates in those children's psychiatric centers. Some of the mobile integration teams or MIT teams that are mobile crisis teams that are based out of psych centers, they're adding adult, family, and youth peers in different ways and in different amounts to their teams. And I think some of, you know, while they're not hospitals, a number of our residential programs also have family partners working in them there. So if anyone else has anything to add to that, please feel free to add it. I think nationally we're seeing more of this work happening, and just for the reasons that folks mentioned today. It's really helping families be more comfortable and have a better experience. It's also helping the information flow and helping families get connected once they're discharged, and having an impact on outcomes. So if the person who asked that question has a particular area that they want to know more about, an area of the state, then feel free to email me later, and we can connect and find out what's going on in your area. Does anybody else have anything else to add on that? Where else this might be happening?
No.
Okay. All right, so we have another question came in that said, are the forms that they use as progress notes for the youth meetings available online? Caitlin?
No, they're not, but my contact information should be on one of the following slides if they're interested in emailing me, and then I can send them. That won't be a problem.
Terrific. We also had Caitlin, a Youth Tower is great comment that came in. So you might want to just take a minute to just let folks know what Youth Tower is. I know you introduced it briefly, but just let folks know what Youth Tower is.
Yeah, Youth Power is the New York State network of young people who have been labeled and are seeking change. So it's a statewide organization, and we have 5 different regions covering Western Region, Central, Hudson, Long Island, and New York City. And we serve to amplify youth's voice within child serving systems. So that extends beyond mental health and goes into special education, juvenile justice, independent living, substance use services, developmental disabilities, et cetera, and making sure that young people get the support they need with the respect and dignity that they deserve. And so we offer a variety of things as far as trainings to technical assistance, to providing youth advisory councils to counties in New York State. So it's a really amazing resource. And if you guys are interested in looking some more information up online, our website is youthpowerny.org.
Thanks, Caitlin. Caitlin, while we're on the subject of youth and the work that you're doing, and I'm going to spring this question on you, but and maybe your partners can help too. Can you identify some really concrete things that have changed, some practices or policies or way of working with youth that have changed as a result of this partnership that stand out in your mind?
I would say, honestly, I see a major difference just within the couple of years from when I was a patient and now working at the hospitals where I once was receiving services from. And the peer movement has shifted significantly even within just the past year. But I feel like the perspective, and Daryl was talking about it earlier, you know, we're talking about hope, strength, and recovery, and these are the main things that we're focusing on instead of what happened or, you know, what's wrong with you. It's now what happened to you, and that's something that's incredibly valuable. And just making sure that, you know, the services that the young people are getting are person-centered and trauma-informed, and making sure that it's all individualized so that the person gets what they need. And making sure that they have a voice within their treatment. That's something that I've been seeing a lot from my providers. They're asking me, what do the young people want? And that's not a question that I heard years ago, and I felt that I didn't have a voice. And even just having the partners welcome a young person onto their team, that's a really big change in the system, and it's happening more and more. And but we're proving our outcomes, and the partners see that. So it's a really wonderful collaboration.
Terrific, thank you. Someone's asking if you could elaborate a little bit on exactly what you're tracking in terms of your data collection. And I know you have some kind of ongoing data collection and then some things that are specific to the research that you hope to do. So if someone could sort of briefly talk about that.
So we're tracking every contact, every referral that we send to the person. We're tracking and looking at if they come back into the hospital, and we're just at that point. Going through this internal review board has been a process. So the current consent that we use doesn't have date of birth on it. The one we're submitting to the IRB, the internal review board, has date of birth so that the area county medical center can let us know if that person's come back in the hospital. So the referral information, we're tracking if families attend support group, attend any of the conferences that we send them, if they follow up on job vocation programs that we're sending them. We link families sometimes to clinics, so the follow-up call tracks whether they've been linked to that resource. And then the 2 surveys that we have not started will track reduction of stress for caregivers, and then quality of life that we're doing with adults. So on the quality of life survey, and I can send that out if anybody's interested, it asks what are the 3 primary concerns on behalf of that transition age youth or adult, and then we're going to work with them on those things. So for someone it might be getting a job, for someone it might be just learning about the mental health system. It might be their social circle, and so that's the information we're providing. So we've established protocol on how many times we're going to call people within a given month, follow them 3, 6, and 9 months out, and then up to a year. Dr. Jeff Anker from UB Psychiatric Associates is working with us and overseeing this process. So we're thankful to him. He's a board member here at the Mental Health Association, and he is committed to meeting weekly with me on supervision. We also have a protocol for crisis. So if we are following up with someone who indicates that they're suicidal, we have a plan in place both with Crisis Services and the Erie County Medical Center. Crisis Services will follow up, and they'll also share that information with a CPEP, the Comprehensive Psychiatric Emergency Program.
Thanks, Jenny. That was really helpful. And I will say to folks that as this research gets underway, once they have some data that to share, we'd be happy to have them back to talk to us a little bit about what they're seeing in terms of outcomes. So that mention of the crisis protocol and the CPEP ties nicely into another question that I see here, which is a lot of what you describe happens after a family has come to the emergency room. And obviously, one of the goals is to see if you can get folks set up with services so that they don't need to come back. But the question is asking, is there some kind of a hotline or some kind of service that you could imagine that would connect with families before they came to CPEP so that you might be able to divert them from that emergency room visit?
So we, again, collaborate. One of the things that we do give out to our schools, our clinics, is a bookmark with mental health services, and that's a collaboration between Families Can, Families Child Advocacy Network, and they're a family group. So we, every year, produce this bookmark with mental health services, and Crisis Services is on there as well as the CARES team. So a family can call any of these contact numbers, website information is on there, and connect for help. And then we're not 24/7. Crisis Services and the CARES team are. They often refer families to our program for help and support.
And this is Mike Cummings, just jump in on that as well. It's an interesting collaboration here in Erie County because Crisis Services is also the ECMC's contracted mobile outreach group, and we're just in the process now of actually having them be able to document directly into our EMR for cases, not just ones that they brought to the hospital, but for mobile outreaches that they've had. So this is going to give us a whole new scope of power to make referrals and then follow up with those referrals on that piece, and it really is. What's wonderful about this program and the ones it works with is, you know, there's no one program that's going to fix everything. There's no one program that's meet everyone's needs. It's really collaborating with multiple programs. In fact, we actually have a different program also funded by the Tower Foundation where we're actually doing mobile visits for very high at-risk youth, typically those with developmental disabilities or on the autism spectrum. And very frequently, we're reaching out to Jenny, and they're able to either provide family support, provide respite. Many of these are children who have not been to the emergency room, and just to your point, the goal is to prevent that from happening. So that's a pretty small-scale thing right now, only working with about 100 families a year, but still, we're already seeing, after year one, some real promising collaboration with the family support program here.
Thank you, Dr. Cummings. So the other thing that I would observe here that I think is a change as we're moving into this new way of thinking about how we provide services, and Dr. Cummings, you alluded to that, which is there's a need for providers to work together differently than they have in the past. It's not you go to this program and they work with you and then they pass you off to another program. It really is much more of a network and linked kind of arrangement. And where that happens, we have seen that family support can be a really important part of that because they can kind of grease the wheels of the system a little bit. They can get in touch with families, they can engage with families and help the families see that maybe there would be some value to connecting with the system. They can also help families connect with informal resources and support so they don't need the formal system as much. So I think you're going to hear a lot of talk about that kind of thinking around family support, not as a program that you go to, although it might also be that, but as a service that works in and among and around all these other services to help things go smoothly for families. We have a question here about health homes. Do you anticipate working with children's health homes once they begin in the fall of 2016? And for those of you who weren't on the Children's MRT call the other day, the health home, the group announced that they were going to delay the implementation of health homes until September of 2016. So that's what that's in reference to. But How do you imagine that you're going to be working with health homes?
We have partnered with, we partner with Baker Victory Services, who is one of the providers. Youth peer support is also a billable service, and as Caitlin mentioned, she has taken the first ever training for youth peer mentors who will be a billable waiver service. So we're staying ahead of the game and trying to market ourselves and let our providers know that we are here to support families in that health home world.
I could speak to that a little bit too. I'm one of my other hats is I'm the program director for the Child Psych program at our children's hospital as well, and the health home piece there is just getting underway. If you look at the qualifying diagnoses for kids getting into health homes, you can essentially have a touch of juvenile justice and asthma and qualify for a health home. And so I really see the interventions that are going to be important with that population, similar to the adult population, but in a different way, to really kind of be those family and community-centered pieces, because, again, what will get someone into a health home will have a lot less to do with a major medical illness or a major psychiatric illness as opposed to a lot of kind of more psychosocial issues, whether they're juvenile justice, school-related issues, or whatnot. And so, you know, I would expect within this community a fairly robust collaboration once the wheels get moving there.
And we are in the process of getting that Medicaid number, so, and that is a process, but we're in that process.
Terrific. How about managed care organizations? What kind of outreach or conversations have you made or had with managed care organizations in your region?
So I'm going to tout our family support. We work closely with the Western Region Office of Mental Health, and they have kept us abreast. We as a program have not gone to any one managed care organization thus far, but that will be the plan. But we meet monthly with our Office of Mental Health regional parent advisor to talk about how we can better market ourselves, as well as with Families Together. Families Together in New York State has a work group, and we are working together to market family support across the state.
And this would be a good point for me to say, too, that CTAC is working with managed care organizations, and as those conversations move forward, we'll certainly be having some discussions around family support and working with those managed care organizations to understand their perspective and also to help them understand how family support is working in different parts of the state. And so I encourage everybody to stay in touch with that conversation through the CTAC website. We are almost out of time. We have 1 minute, and so I want to take, there is a question about the form, but we'll reach out to that person separately around the consent form, so I think that'll be easier done in person. And we have a comment from someone who says, as the Youth Transition Coordinator at the Independent Living Center in the Hudson Valley in Troy, New York, what can I do to support youth with mental health needs? I believe so strongly in connecting with other organizations, so I look forward to hearing how that can be made and what I can do to support youth and their families. I think this is a question about how you start these partnerships so that you can help be beneficial to youth and families. It's a great way to end.
Well, I think,
Any comments?
I think one of the most important things, like for me as a youth peer mentor, especially being linked to an organization, something that I find helpful when it comes to supporting young people is making sure that I have access to information that I can pass on to them. So if they're, if they're wondering about support groups, or if they're wondering about self-help apps, making sure that I have the information, or I at least have the resources to go find the information to make sure that I link them to what they need. And also just making sure that, I'm present. That's one of the most important things. And if I feel that there's a need for something, I feel that I have places that I can go to and people that I can talk to in order to advocate for the young person to get the supports that they need. But it goes in, it's 50-50, you know, making sure that you're advocating for the young person and also just making sure that you're supporting them as well and making sure that you're listening to them. If they're struggling with just simple, you know, just life issues, if they're struggling with school and something like that, you know, it's okay to just let them talk for 45 minutes. Sometimes that's one of the most productive meetings you can have with the young person. Or if they're really struggling with something and you feel that you need to connect them with an organization or you need to reach out, then figuring out, okay, who can I talk to in my community? Who are some resources or who are some people that can help strengthen the connection to make sure that I can help serve the youth that I'm working with. So having access to community resources is one of the most important and helpful things I find when helping young people.
Well, thank you, Caitlin, and thanks to all of our presenters and all of our attendees for taking the time to get together and learn a little bit more from each other. We've reached the top of the hour. I'm sure this won't be the last time we will want to sit down with this great partnership team from Erie County. And I want to wish everyone a wonderful weekend and get in touch with us if you have any questions, and also get us in touch with us if there's something interesting going on in your community that you'd like to share with other people. So with that, I want to thank everyone and wish you a happy weekend.
Thank you, Ann and Brianna and Jack Woodworth.
Bye, everyone.
Bye-bye. Thank you. That was great. We're going to